I think what's fun about this talk is this is a critically important talk about acute coronary syndrome. And we're going to do it in 30 minutes with roughly 36 slides. So can we pick out the things that will make the most sense to you, make the most impact to you and your patients, and help you do a little better job tomorrow than you did yesterday taking care of chest pain patients? I think we can. And I think there are some very interesting aspects of acute coronary syndrome that are overlooked on a daily basis. And it doesn't matter if you're a physician assistant, it doesn't matter if you're a nurse practitioner or a physician. I think all of these concepts are equally not understood well or not used in a practical sense, and that's what this discussion is all about. So hopefully there'll be something in this for everyone. You know, when coming out here to talk to you, I thought about some recent data that I looked up, because there's been, you know, sometimes you work with somebody and you think, you know, how could they get to where they are today? So PAs, nurse practitioners, have you ever worked with a doc, you're like, please, I know I'm smarter than this person. There's no freaking way that you are supervising me. I need to supervise you. I'll put your depends on, whatever it is I need to do to keep you moving, I'll do it. Do you ever feel like that? And I'm sure that some of the physicians sometimes are like, I'm the physician, and so I'm clearly more intelligent. I mean, there are some barriers here that really are not real. Well, I looked at this data recently. It was for a different lecture for the American College of Emergency Physicians regarding staffing models, et cetera, with non-physician providers and workforce issues, just a little bit like what we talked about this morning, but expanded a bit. And I wanted to dispel that myth. And you know what's interesting? You look at all of the IQ scores and all of the assessments that are out there, healthcare providers are lumped together. They're way at the far end of the spectrum. Most wicked smart people really are. And then you sit here and wonder, I really chose to go into this with everything going on at this point. Couldn't business have been easier for me? So that doesn't make us look that smart, but in order to accomplish what we have to complete our training, we're pretty smart people. But there is no breakdown. There is not one shred of evidence to say those who choose nursing, those who choose to be a physician assistant versus those who choose to be a physician and go to medical school are smarter or less smart, less intelligent, more intelligent than any others in the group. It's just a career path, an educational path. So another good reason to respect each other when we're working together. All right, so let's talk about this. And you see this first slide and you see images and you're thinking, oh God, we're going with anatomy. If we're leading off with anatomy, this is going to be an ugly 30 minutes. Well, from one respect, you go, well, it's 30 minutes. I can live through almost anything for 30 minutes. But I'm not going to talk much about anatomy. This is just for your visual pleasure. You can take a look at this. But what I do want to talk about is vascular anatomy. And I think if there's a fundamental understanding of vascular anatomy, and then you combine that with your understanding of ECG, and you take a look at that, you can really get a sense of who's at risk for a complication, who's at risk for a bigger piece of myocardium being impacted, and where do I want to look on the ECG for abnormalities. It all comes together. From my perspective, and the way I was taught, it was all fragmented. Anatomy professor talked about vascular anatomy. Somebody else, a cardiologist, talked about ECG interpretation. And somebody else talked about physiology. It took me a long time before I put all those pieces together so it made sense. I want you to think about two arteries, and that's it. You've got the left coronary artery. You're with me? I see your pen's ready. Two. You've got the left main coronary artery, and you've got the right coronary artery, okay? And off of the left main comes the circumflex and the left anterior descending. So if you look at the front of the heart, the left anterior descending is coming right down the center of it and serving that left ventricle. If you have a proximal LAD lesion, do you think you have put a huge piece of myocardium at risk? Yeah, you absolutely have. Well, what's branching off at the same time as the LAD is the circumflex that's going to come around the back side of the heart or the side of the heart and go to the inferior wall. So if you have a proximal lesion that maybe even is proximal to that junction point, you can have even a larger piece of myocardium because you've got the whole left main trunk, and that can happen. Left main disease, that's a bad, bad thing, and that can kill people very quickly. All right, so you've got the right coronary artery. There's no right circumflex, so don't worry about that. You've got the right coronary artery, and there's a right marginal branch. That goes to the inferior wall. And then you've got the posterior descending, which when you look at the back side of the heart, when you have the two images, the one beneath it is the back side of the heart, that looks like a pretty sizable chunk of myocardium too, doesn't it? The problem with an ECG is it seems one-dimensional when we look at it. They try and make it three-dimensional by saying, well, the limb leads are giving you kind of a vertical perspective, and the chest leads are giving you a horizontal perspective. Therefore, it's 3D. Do you see any 3D when you look at that? That looks flat to me. I don't see anything. 3D glasses don't help it. It looks one-dimensional, and we just don't get a good sense of where injury can take place when we see certain abnormalities on the ECG. So the back side of the heart, if you have a posterior descending artery, you're going to have a posterior infarct, and it's going to be a huge piece of myocardium also. Here's something that'll be very important for you to remember, okay? 100% of inferior wall MIs are going to be caused by either the circumflex or the right coronary artery, the right marginal branch. 80% of those are the right coronary artery. So when you look at an inferior wall MI, you look at that picture, and you look at it on the ECG, and you've interpreted correctly, you know already by vascular anatomy that 80% of those are going to be right-sided MIs. In the past, I used to do this 21-lead diagnostic ECG to see if they had a posterior or a right-sided MI. And you can do it, and it's a great clinical way to waste time. You don't need that extra information, those extra leads, because you already know the vascular anatomy tells you that almost all inferior wall MIs are going to be from the right side. Now, whether they're going to be clinically relevant or not, and we'll talk about as we're coming up in a few slides, meaning that you're going to have to treat them differently because they're right-sided, depends on how the patient presents, and we'll talk about that. So inferior wall MIs frequently get what type of complication? Hypotension? Yeah, they can. What about dysrhythmias? Yeah, they get heart blocks, right? They get them frequently because 60% of the time the SA node gets its blood supply from the right-sided system, okay? And 40% from the circumflex. And the AV node is 90-10 with those two vessels. So when you look at bradycardias and you look at the SA node and the AV node, no wonder it's frequently associated with inferior wall MIs, because the blood supply to those two areas is always coming from the two vessels that are also responsible for all inferior wall MIs. So what that tells us is if you've got a bradycardia with an inferior wall MI, if you reperfuse them, then you reperfuse that conduction area, the SA node or the AV node. Unless it's completely destroyed and queued out, you can get it back. They don't need a pacer right away. But with an anterior wall MI, if they're bradycardic, does the LAD perfuse either the AV node or the SA node? We just talked about it, does it? No. So what that means is if you are bradycardic with an LAD lesion, that means you have necrosed and infarcted all of your septal conduction tissue. There's no pacemaker for that. That's not coming back. What you're going to have to do is electrically pace them. They're not going to get better. And they very well may not be atropine sensitive either. You never know. You'll give it a try. But that's the difference. And with vascular anatomy, knowing where the infarcts are caused from and what those vessels supply, it gives you a really good sense of what complications to note depending on what you see on your ECG. So I hope you don't mind me spending 5 minutes or so, maybe 9 minutes, talking about that. But I think it kind of brings things together quite a bit. All right, now let's talk about the spectrum of acute coronary syndrome and the variety. Unstable angina, what is that? A new onset of chest pain that you think is angina is unstable angina until proven otherwise because it's brand new. And we also have to think about those that have a changing pattern, a pattern that was previously stable. As a matter of fact, I don't think there's any such diagnosis or impression in the emergency department as stable angina. Because if somebody has stable angina, they mow their lawn every Saturday, they get chest pain, they finish half the lawn, they sit down in a lawn chair, they drink some lemonade and take a nitro, it gets better, they get up and they finish the lawn, that's stable angina. If you had stable angina and it's reacting the way it normally does, why would you be in the emergency department? So by definition, I'd be very careful labeling somebody in the ED with stable angina. And you're not going to have an enzyme response. Remember, there's no infarct here. No ST elevation. You might have some ST depression on the ECG. And it can occur at restoration, maybe around 20 minutes. You'll have to see. Sometimes there's stuttering pain as well. A non-STEMI, that's when you're going to have an enzyme response, but you're not going to have ST segment elevation. That's non-ST segment elevation MI. You might have ST depression, and remember, this is a partial wall thickness MI, previously known as a subendocardial MI. Now, the STEMI is full thickness, and you're going to have elevated troponin as well as ST segment elevation or a new left bundle branch block, or there's an injury pattern superimposed on a previously existing left bundle, and you can't see the new injury pattern superimposed there, so you make the presumption, if the story sounds good and they have a left bundle, you'd rather err on the side of treatment as opposed to not treatment. Something else that's important, a lot of people say, well, great, a non-STEMI is going to have a better outcome than STEMIs because it's only partial thickness and not full thickness. That's actually not true when you look at the literature. A non-STEMI or subendocardial MI just means they haven't finished their work yet. They will infarct again if the intervention does not occur appropriately and effectively. So actually outcomes with those patients with subendocardial MIs tend to be worse than those who just complete their STEMI and be done with it. All right, findings in ischemic, cardiac, or chest pain. There can be any combination of pain, and you just don't want to discount what kind of pain a patient would have or symptoms they would have, assuming that it isn't acute coronary syndrome. So the classic substernal tightness or pressure radiating to an arm, to the neck or the jaw, diaphoresis, shortness of breath, those type of things. It's great if you have those symptoms. Nobody misses classic symptoms. And the people who write textbooks give you the classic presentation. We have to practice based on reality. And the reality is patients may not be the best communicators, and they do not have to experience their symptoms the way the textbook was written. As a matter of fact, most of them haven't read it. Although some of them have. You've encountered those patients. They already know their diagnosis and their treatment. They're just asking you to facilitate their treatment plan. Sometimes that happens. How about jaw or arm pain? Well, you know, some people say, well, if it's right arm pain, that can't be cardiac. No, it's no less likely. Diaphoresis, I think, is a very important finding no matter what the situation is. Not being sweaty and warm because you've exerted yourself. Cool and clammy is never a good thing. And associated with important symptoms like chest pain, it shouldn't be disregarded. Symptoms may be gone upon ED arrival. That is so true. So take them at face value the way they describe them. And remember, fatigue may be all that you see from an elderly person or somebody who has atypical symptoms. So our initial treatment, we're going to put them on the cardiac monitor. How many times does the cardiac monitor alarm go off in the ED during one of your shifts and you do nothing, you don't even look at it? It's okay to say it because it's true. You've been conditioned that those alarms mean nothing. Several articles on this, one that came out in American Journal of Emergency Medicine in 2006, looked at all kinds of hours of telemetry. 99.4% of the alarms were false alarms. And we've been conditioned to not look at them. Ventilator alarms, different situation. Always something bad going on there. And when we hear them, we react to them. And that's why they have different tones, because if the ventilator manufacturer used the same tone as the cardiac monitor telemetry manufacturer, well, we'd be missing a lot of people who are having trouble on vents. So telemetry, yes, but we aren't likely to find a lot there. Oxygen saturation is very important. I think it was Archives of Internal Medicine in the last couple of years reported that oxygen is not always good. It is a drug. And I'll limit my comments to acute coronary syndrome. If saturations are 92% or above, you do not need supplemental oxygen. As a matter of fact, with the LAD and with the other coronary arteries, the vascular resistance goes up when you increase oxygen tensions when they have saturations above 92%. So we're giving nitrates. We're doing all these things to dilate them and to better perfuse them. And what are we doing by dialing up the oxygen so they're 100%? We're actually causing a reflex vasoconstriction of the coronary arteries. That is what we're doing. And I'll tell you, I'm having a battle everywhere I work. I work at 3 sites right now, and when somebody comes in with chest pain and I turn off the oxygen, I want to tell you what, they think I'm the worst doctor in the world, but they have chest pain. They need extra oxygen. Well, the Heart Association and many others have taught us that for years, that that's the right thing to do. I'm here to tell you, if the saturation is 92% or above, not only is it not necessary, it may actually be harmful for people. ECG within 10 minutes of all comers with chest pain, because we don't know who's having the MI up front, and make sure it's reviewed immediately. You should have a policy in your department where, It's handed to the provider, not put on the chart. I've had too many cases I've reviewed where the ECG was just placed on the chart and put in the rack, and 2 hours later when somebody gets to the patient, there's the STEMI. That's not acceptable. And I think you should also have policy built around getting an old ECG. Why should you have to think about it? Maybe it would be a good idea if I reviewed the old one and compared it. Why doesn't it automatically come with the new ECG when it's ordered, if one's available? It should. That should be protocol-driven and policy-driven. The American College of Emergency Physicians drafted a clinical guideline in 2006 about chest pain, and one thing they said was, level B evidence, but still a reasonable consideration, that getting a second ECG in 30 to 60 minutes from the first is probably a good idea, because there can be evolving changes even if the symptoms haven't changed. And the negative predictive value of 2 normal ECGs is really very, very valuable to you, and the negative predictive value is excellent. So having 2 is important. Again, why should you have to go and remember to order the second one? It should just happen. And so I would definitely make that part of your protocol in your department. If you know that, that you are concerned about acute coronary syndrome, and if you're already working them up, you should make sure they get some aspirin. Up to 325, but I tell you what, the benefit starts at 162 milligrams. And I haven't seen any literature that has proven that beyond 162 there's additional benefit. But you certainly don't need to go beyond 325. Okay, get some IV access. If you're a physician assistant or a nurse, you may want to consult the doc about what strategy you want to use to treat the pain. Remember, nitrites and Viagra, bad idea because they both vasodilate. You should get that history up front before you give nitrates. And you can precipitate a situation where the patient has a non-resuscitatable hypotension. Don't give it to them if they're on these medications. Funny story about the history of this medicine. Viagra wasn't called that then, but when it first came out in the mid-90s under trial, it was an antihypertensive. It performed miserably. It was horrible, so they stopped the trial. It just wasn't performing as well as current things on the market anyway. It wasn't really hurting anyone, but it wasn't working. They recalled the trial. They called all the study subjects and said, hey, just send your medicine back. We're done with the trial. Nothing came in. They said, over my dead body will I send this back. And they said, well, why? Because I've had an erection for 4 hours, and that hasn't happened in a long time. So that's why this drug now has this sole indication, not an antihypertensive, but for erectile dysfunction. But it has kind of an interesting history behind it. So be careful with it. Routine labs are important, but I would say you don't have to overdo it. Coagulation profiles, if you're not heparinizing a patient, standard use of PT-PTT is unnecessary. And I would go one step further. If you look at the data, even heparinizing them, you're going to get the PT-PTT if you're using unfractionated heparin down the road to manage it. You don't need it up front. You need a platelet count to make sure you get a platelet count baseline in case they get heparin-induced thrombocytopenia later. But you don't need that PT-PTT up front. And if you're using fractionated heparin, you don't need it either because you're not going to follow those. So why do we always get them? Lots of money spent. Stat portable chest x-ray, sure you can look for CHF, look for signs of a dissection, but if you're really worried about a dissection, the only test to get is a CT scan. Our most sensitive finding on a chest x-ray is going to be widened mediastinum, and depending on who you read, that's still only about 70% sensitive for dissection. Is that a good enough screening test before you subject somebody to anticoagulants? Probably not if you're worried about dissection. So heparin and clopidogrel or Plavix, yes, if you want to keep the vessel open, that's what you need to do. Remember, heparin doesn't open the vessel. It just keeps it open once it's been opened. So it doesn't have to be your first choice or your first drug. If it's an MI, you can use unfractionated heparin, 60 units per kilo IV push, and then 12 units per kilo per hour maintenance. If you want to do, let's say, fractionated heparin, Lovenox, you can do 30 IV push, and then you can do your sub-Qs after that Q12 hours. And clopidogrel is across the board. Some people say between 300 and 600 loading dose. I've seen some data to say that maybe 75 is just enough. But consult your cardiologist. You may want to talk to them. Decide if you want to get some on board. They can always add more to it. Cardiac markers. There's no value in an MB or a total CPK. An AST, an LDH, any of those markers, they're old, retired, done, a waste of money. Troponin is all you need, and most people go with a troponin I. Elevations rise 3 to 6 hours, peaks at 12 to 24 hours, and the beauty of this test, it normalizes at about 7 days. I have never understood serial troponins once it's elevated and you've infarcted. Are they really surprised every time it comes back elevated? The lab is compelled to call every time with that alert value. Your person's had a STEMI, they just went to the cath lab, and another positive troponin. You don't understand how the test works. So we don't need to order it again unless you think there's been maybe another event. The supersensitive troponins. This is going back in time to where we were a decade ago, with, or maybe even more than that, with myoglobins. Very sensitive. It'll pick up everybody, but we admitted people with positive myoglobins that didn't have disease. Wasted money. And I believe this is more expensive, and it's the same concept. Canadian Medical Association Journal 2012 published an article very pro about highly sensitive troponins. It said, look, we picked up everybody, and we picked them up earlier. The problem was over 44% of those that were positive were false positives. Almost half of the people that they thought had an event didn't have one. So this is a very expensive myoglobin, in my opinion. I wouldn't use them. These are the things that can cause troponin elevations without having an infarct. We used to think when troponin first came out, well, this is it. It's better than MB for a variety of reasons, but also because it's so specific. Well, we have found out over time it's not that specific. Lots of things can cause it. One conundrum is myocarditis. We think you see somebody with a funky ECG with a lot of ST segment elevations and chest pain. Are they having an MI, or is this pericarditis myocarditis? Well, the troponin's elevated. It's got to be STEMI. Well, not necessarily. As you can see here, 16% of patients with myocarditis are going to have an elevated troponin. The other one that worries me, you can look at the list on your own, but sepsis is huge. You get a hyperdynamic heart, you can have troponin leak, okay? And the biggie on this list is not pancreatitis, not renal failure, although you probably saw with MBs, and we know with troponins as well, renal failure gives us a false positive, but it's not necessarily a true positive. So we're looking at multiple different things, but PE is the big one. Another entity that causes chest pain. And when the troponin's elevated, what do we do with our differential diagnosis? We shut it down. Great, positive troponin, chest pain. Wow, it was kind of pleuritic and you had some risk factors for PE, but I guess it's a STEMI, or I guess it's a non-STEMI. I guess it's cardiac. Well, if you really think they have a good story and risk factors for venous thromboembolic disease, don't let a positive troponin steer you away from doing the workup to make sure they don't have PE. That is huge. Hugely important. The other thing I like about troponins, different than MB. False positives with MBs didn't mean anything. If you've got a troponin that's positive for some troponin leak, it is a negative prognostic indicator for you down the road. Standard renal failure patients, not sick today, you just have renal failure, you go to dialysis, you have a positive troponin, the chances of you being dead in 12 months are excellent. So maybe you just don't order the test, I don't know. Or maybe you let people know, oh, your troponin's up today. Can we end dialysis a little early? I got things to do. I mean, but that is an important prognostic test that you can look into, but that MB did not have. It was just a false positive. But troponin carries with it some prognostic values, even when the leak may not be cardiac related. All right, treatment for STEMI. The key and the gold standard is going to be percutaneous coronary intervention. Get into the cath lab. But you've got to be able to get the balloon up in 90 minutes, not to the other hospital, not to the cath lab, not on the phone with the cardiologist, but balloon up in 90 minutes. If you can't, you've got to start thinking about thrombolytics. And if you use thrombolytics, you want to administer the drug within 30 minutes of arrival. Okay, the elements of the ECG. Let's talk about this in the context of acute coronary syndrome. Here's a normal. That's a good starting point, isn't it? So everything looks fine here. No issues. But what do we see with ischemia? Well, you can have horizontal or downsloping ST segments. Here's some downsloping. Horizontal, if it's completely horizontal, particularly with a T-wave inversion, think more subendocardial infarct, non-STEMI. More of those patients will have it than those who have downsloping ST segments. And one thing I want to point out, you see the circles here. You see the ST segment depressions. You see also in the lateral leads, the ST depressions. Maybe you're starting to get a T-wave inversion. But look at AVR. AVR has a little bit of ST segment elevation. There's pretty good evidence to say that if you've got even 0.1 millimeters, so you've got one box of elevation in AVR, that a good number of patients are going to have proximal left main disease. That is a huge pearl, I think. And a lot of us weren't aware of that until recently, but several articles have come out to say, you know what, it's a pretty good predictor of it. If you're dealing with somebody with chest pain and you see that, if that's a lead that you have ignored for years, don't ignore it anymore. It's important. All right, the sequence of an MI. So 1 minute after onset, we're going to get our hyperacute T wave. Then 1 hour or so, ST segment elevation. If we start to necrose tissue, we'll start to get our Q wave. Then as things move on, a few hours later, we get a deepened Q wave. And we maintain the ST segment elevation if this hasn't been treated and there's still an occlusion, and we start to get some notching at the terminal segment of the ST segment near the T wave. You can see it further a day or so afterwards when you start to get an inverted T wave. And then finally, a few months after, things go back, they're completely back to normal. The T wave flips back. You might have some non-specific changes, but otherwise, with the exception of the Q wave, which is permanent necrosed tissue, everything seems to be back to normal. One thing I'll throw out at you as another pearl, I hope it is anyway, is be very careful using the term non-specific ST changes in your documentation with an interpretation. Up to 23% of patients who have underlying coronary artery disease have non-specific changes. Doesn't mean it's what's causing their symptoms, but if you're putting that in your interpretation because you believe it to be a benign statement, it's not. Say that there are no significant ST segment changes, that's fine. But non-specific ST changes may indicate that, like I said, up to 23% could have coronary artery disease. All right, anterior wall MI, and we'll move through these quickly. ST segment elevation, V1 through V3. And you can see in this ECG, we're getting some lateral wall involvement because we have V4 and V5 with ST segment elevations. Remember, this hypothetically three-dimensional picture, if you have a large enough piece of myocardium involved, and the current of injury is headed toward that electrode, you're going to get a positive deflection. And if you have a large enough piece of myocardium that the opposite electrode, as far away from this as we can get, sees it, it'll be a negative deflection. That negative deflection is known as a reciprocal change. And if you see the reciprocal change, it locks it in pretty much for the STEMI. You don't have to have it, but if you do have it, it's very important. So with an anterior lateral wall MI, you would like to see inferior reciprocal changes, or at least it would help you. Not that you want the patient to have them because it's a larger area of myocardium involved. Another good example of an anterior wall MI, and I think you've got lateral involvement there too. You see it in V4 and V5, and also look at 1 in AVL. Anterior wall MI with left bundle branch block. This gets tricky. When in doubt, left bundle branch block and it's new and you have a good story, it's a STEMI. If it's old or you can't find out, err on the side of treatment. Send them to the lab. But there are some things you can do. Something called the Scarboza criterion has been met with some criticism, but it does help a little bit. That if you see, particularly an ST segment elevation, in a lead where you expect the ST segment to go the same direction as the QRS complex. So let's look at V5 in this particular ECG. If there's 1 millimeter of ST segment elevation there, that's a STEMI. And you see it here. If you look at the anterior precordium, V1, 2, and 3, where you expect there to be repolarization change in a large ST segment elevation, 1 millimeter of ST segment depression there, that's a STEMI. And because in V1, V2, and V3, we expect there to be repolarization change and ST segment elevation, you need a lot of additional ST segment elevation to call it a STEMI there. It requires 5 millimeters or more. And I think you see that here too. So this is anterior wall MI superimposed on a left bundle branch block. All right, lateral wall MI, very simple. 1 in AVL, and the most commonly misdiagnosed vascular pattern for MI is the high lateral wall, 1 in AVL, not involving anything else. Lower risk, smaller piece of myocardium, but nobody wants to miss an MI. Do we see reciprocal changes? We do in the inferior leads. In 3 and AVF, we have ST depressions, which tell us lateral wall, and we've got our inferior wall reciprocal changes. Good example here of a lateral wall MI. Inferior wall MI, ST segment elevations 2, 3 in AVF. We might start to develop those cues in those same leads when we have necrosed tissue. Do we have reciprocal changes? Well, in an inferior wall MI, we'd expect to see them where? We'd expect to see them laterally. And I will tell you, if anyone tells you there's a reciprocal change at the anterior precordium, they are misleading you, and you could end up missing something important. Because any ST segment depression, which we'll talk about in a few minutes, in the anterior precordium should be considered a posterior MI. as opposed to a reciprocal change. So don't ever look at ST depressions in V1, V2, and V3 and say, oh, well, it's a reciprocal change for an inferior wall MI. Instead, perhaps maybe you have an inferior wall MI and posterior extension with that inferior wall. Another good example of the inferior. In a true posterior, if you're not even involved with the inferior wall, this is just the posterior descending, you're going to have a tall R wave, V1 and V2. And here, this is easy. The R to S ratio should be greater than 1. So the R wave is greater than the S wave. That's all you need. You're going to have ST segment depression and upright T waves. That's the end of it. You can have an R to S ratio greater than 1 with other things, like right ventricular hypertrophy, RV strain, that sort of thing, right-sided heart failure, COPD, pulmonary hypertension, lots of things, but not with ST depression and upright T waves. That's different. All right, now let's talk about this issue of inferior wall combined with a posterior. We talked about what can happen. So you've got your right coronary artery, you've got your right marginal branch, you've got the inferior wall, but it's a proximal lesion in the right coronary artery, so you also have the posterior descending. You have a huge piece of myocardium, at least as big as the anterior wall, if not bigger. ST elevations, 2, 3, and AVF, and look, we have posterior changes. The R to S ratio may not be to 1 yet, but don't wait for it. You see everything else there. Very important. What you can do, and some of us were taught to do this, is that if you want to see the electrical injury pattern on the back of the heart, you can just flip the ECG upside down and turn it around and hold it up to the light. Because although they say it's 3-dimensional, it's 1-dimensional. And we're seeing the negative deflection because we are looking at the anterior precordium. The leads are here, but the injury pattern's back here. The injury pattern is going away from the leads, so we're getting a negative deflection. If you want to hold it up to the light and flip it around, do that. Just do it in private. Don't do it at the bedside. It does not instill confidence in your patients that you know what you're doing when you're like, doctor, that is backwards and upside down, I'm fairly certain. Don't do it. Special considerations. Don't let age fool you. MIs do happen in the young. There is a pretty steep curve at 40 years of age. No risk factors in 40 and younger. It's much less likely, but it can still happen. Relief with a GI cocktail or nitro should not tell you what to do with the patient. You can give nitro. It doesn't mean it can't be GI. And it's not confirmatory that it's ischemic. Now, I think a lot of our admitting physicians still think it is, so then that's great. That's an automatic admission. Don't tell them, well, it's probably still GI, but they got better with nitro. But GI symptoms can come along with an inferior wall MI. Remember that, okay? So think about risk factors as red flags and add it to your decision-making, but don't think that people can't have an acute coronary event without any risk factors. They certainly can, and here's some common risk factors listed. One other pearl I'll give you also is don't run into the room when someone has a change in status. They now don't have pain or they do have pain. You think you're going to catch the event because they just had an increase in their chest pain or a new episode of chest pain. The data is pretty clear that if you run in and do that, you are no more likely to identify the change than if they were sitting there acting like they felt okay when they came in. You want the 2 ECGs, but it doesn't have to be timed with an event they had. All right, non-STEMIs and STEMIs may take some time, so you've got to do serial troponins and ECGs. How many of you send people home after serial troponins? How many of you? A few. Okay, how many is it? 2 troponins, 3 troponins, 4 troponins? The point I'm making here is you may be able to reliably rule out an infarct, but can you rule out unstable angina and the full spectrum of acute coronary syndrome with serial troponins? No. We know that, depending on who you read, between 2 and 4% of MIs are sent out the door, and we don't know we're doing it. And twice that number of unstable angina patients are sent out. Well, if we're relying on enzymes to rule out unstable angina, well, we're going to keep making mistakes. If you're worried enough to get repeat enzymes, maybe they need to come into the hospital. You need to be thinking about that quite a bit. All right, anterior MIs are usually the most symptomatic. Big piece of myocardium, they can go into cardiogenic shock and congestive heart failure, but it's not from volume overload, it's from a lack of inotropic squeeze. So be a little bit careful about using the traditional treatments that you would to preload reduce them. They may need afterload reducing, but that may need a balloon pump to do that, and they also may need pressure augmentation. So little different situation, not like your traditional CHF patient. Inferior MIs we talked about a bit, and some of that information I gave you up front was to preface this conversation. So if it's a right-sided MI, and the patient is in right-sided heart failure, Lungs will be clear. You'll have JVD because the right ventricle is just kind of laying there pumping ineffectively, and the fluid is collecting, the blood's collecting, so you can get right-sided heart failure and JVD. You don't have time to develop lower extremity edema yet, and your lungs are clear because it's right-sided heart failure. If it's a left-sided inferior wall MI or anterior wall MI, and they're in cardiogenic shock and they have rails, you know that it's left-sided. But a right-sided MI will give you hypotension because of preload reduction, not an inability to get the fluid out of the left side of the heart and backing up into the lungs, okay? Very important. So what do we do with people who are symptomatic with a RV infarct? We give them a dose of nitro. Be careful. If you know it's an inferior wall, most of them are right-sided, be careful. Give a nitrate. If the pressure drops, don't give any more. Fluid augment them because the RV, the right ventricle, is just now a conduit of blood flow to the rest of the body, to the other part, to the lungs and the left side of the heart. So you have to push it there with more fluid. If you preload reduce with morphine, nitrates, and those type of things, you will make it worse. So you can't do it. And you can make that diagnosis at the bedside. You're hypotensive, your lungs are clear, you got some JVD, acute right-sided heart failure, inferior wall MI, I need to preload augment you and not preload reduce you. And that's a distinction you can make within 2 minutes at the bedside if you know what you're looking for, and I believe that you do. All right, level 5 documentation. Clearly somebody that's sick, you can certainly claim level 5, and if you're allowed to in your area as an advanced practice provider, you can certainly claim critical care for that. Thrombolytic indications, you're probably very familiar with them, but chest pain greater than 30 minutes, less than 12 hours, not relieved by nitrates, and they still have their ECG changes. You're going to want at least 2 contiguous leads with 1 millimeter of ST segment elevation or the new left bundle. And the other indication is if you can't get them to the lab with the balloon up in 90 minutes, think about it. Here are the absolute contraindications. I won't bore you with this. And the relatives, be thinking about it with thrombolytics of who might have a bleeding complication. That's the only reason we're considering these. All right,